This is part 3 of the unit on neuro problems, and we're going to specifically talk here about brain tumors. So with brain tumors, we can have masses that are within the brain or even the spinal cord. About half of these can be malignant, meaning they will infiltrate the brain tissue. Primary brain tumors rarely metastasize because they're contained within the cranial vault. But unless treated, all tumors will result in death. So to differentiate, we have primary brain tumors and secondary brain tumors. So the primary ones are those that arise from tissues in the brain. And then the secondary ones come from someplace else in the body, and these are the most common brain tumors. Most often, these cancers arise from lung or the breast. The clinical manifestations of brain tumors vary depending on the location and size of the tumor. As you can see, there are many different symptoms, most of which are very vague. You'll need to consider the whole patient and listen to all of the different problems he or she describes. The most important takeaway message is that despite what type of brain tumor it is, we're worried about increased ICP, cerebral edema, and possibly hydrocephalus, which is caused when there's an obstruction of the CSF flow. Headache is a common symptom, and usually these are worse at night. They're often dull, constant, or they may be throbbing at times. Then new onset seizures is really a red flag. We have to worry about a tumor with new onset seizures. The patient may also have memory problems or personality changes that are sudden, or they may have muscle weakness, aphasia, or visual spatial dysfunction. They may be at risk for hydrocephalus, an increased ICP that goes along with cerebral edema and obstruction of CSF flow. So let's begin the nursing process for a patient with a suspected brain tumor. First, be sure to get an extensive history from the patient and the family, and focus on the individualized symptoms the patient is experiencing. The subjective data is just as important as the objective data for these patients. Then you're going to perform a comprehensive neuroassessment, just like you did for a patient with increased ICP or a head injury. Be sure to document that data is complete so you have a baseline to compare the patient's progress to. On the right of this slide, we have a variety of tests that may be ordered to assess the patient with a possible brain tumor. An MRI, a PET scan, a CT scan, an EEG are common. They may also do angiography or even endocrine and histologic studies. The nursing diagnoses for the patient with a brain tumor include but are not limited to these on the slide. Notice the first one is risk for ineffective cerebral tissue perfusion. Yet again, this is our primary goal. We need to relieve that extra volume inside the skull to ensure tissue perfusion. There's that cerebral edema again. You can see how most of our interventions will be based on the increased ICP and edema. Then, of course, we also need to consider acute pain, anxiety, the possible complication of seizures, along with increased ICP and failure of normal compensatory mechanisms. One of the priority nursing interventions for the patient with a brain tumor is protecting the patient from self-harm. Remember that these patients may have sensory, behavioral, and personality dysfunctions, and this places them at risk for harm because of irrational behavior, memory loss, impulsivity, and confusion or even disorientation. So the nurse needs to consider close supervision of the patient. What are we doing with the side rails? We may need to pad them. We should have judicious use of restraint. Some people need them, others it just makes things worse. And they should be on some kind of fall prevention. We want to use a calm, reassuring approach to these patients and minimize stimuli. Create a routine and do some reality orientation. Be aware that they may be at risk for seizures, so we do want to institute those seizure precautions and even anti-seizure medications. The psychosocial care for these patients is really important. A patient with a brain tumor has a very grim prognosis, so superior psychosocial care can be very beneficial. You should encourage the patient to provide as much self-care as possible. This will help promote a positive self-image and allow for some independence. If your patient has language deficits from the location of the tumor, a communication should be implemented that works best. You should actively assess for depression and suicidal thoughts in these patients and do this more than once. These patients are also at risk for inadequate nutrition, whether it be from the inability to eat, loss of appetite, or depression that has decreased the desire to eat. We may also need to consider enteral or parenteral nutrition if needed. Here's some goals for our patient. We want them to achieve control of their pain, control of vomiting, and any other discomforts that they have. We also want to maintain normal ICP and neurological function. We want them to eat properly, so obtaining optimal nutrition is important. And of course, we want them to accept the long-term consequences of their tumor and its treatment. The patient with a brain tumor may often need cranial surgery, and there are other reasons for cranial surgery, such as abscesses or vascular abnormalities, trauma, or a seizure disorder, or even intractable pain. From all that we've covered thus far, you can see how a patient with increased ICP, whether it be from bleeding, a tumor, cerebral edema, hydrocephalus, may need to undergo cranial surgery. So, what do you need to know if your patient does have surgery? Preoperative teaching is really important for the patient undergoing cranial surgery because their anxiety and fear is very high. The best thing the nurse can do in the pre-op period is to educate the patient and the family to reduce the anxiety and fear. Let them know the general information about the procedure and how the patient will appear. Let them know that the hair may be shaved. There may be drains, incisions, and staples on the head. This is all very scary for the patient and the family. Let them know that the patient will probably go to an intensive care unit after the surgery for close monitoring. In the postoperative period, the nurse has a lot of responsibility. The primary goal, again, is to prevent an increase in ICP. You'll need to perform frequent neuroassessments for the first 48 hours post-op. Monitor for fluid imbalances, serum electrolytes, especially sodium, and osmolality because you're concerned with the onset of diabetes insipidus, where the patient loses a lot of fluid. We can't afford for these patients to become either hyper or hypovolemic. We also need to control pain, nausea and vomiting, and we need to keep the ICP down. Assess the dressings and document the color of the drainage, any odor, and the amount of drainage. Notify the healthcare provider immediately for any signs of bleeding or clear drainage, which might be CSF. Also, prevent infection by performing meticulous incision care. And don't forget your general postoperative patient care. You'll want to avoid encouraging the patient to cough, though, as this can increase ICP. You can, however, encourage deep breathing and incentive spirometry. Postoperative positioning is generally with the head of the bed up at least 30 degrees. Again, beware if the head of the bed is above 30 degrees that it may decrease CPP by decreasing the MAP. Notice if the surgery was performed through the posterior fossa or burr hole. These patients will have the head of the bed flat or at 15 degrees at the most. And if the patient had a bone flap removed or a craniectomy, The patient will be positioned on the unaffected side. Preventative nursing care is so important for these patients because they'll provide the patient with the best rehab possible. So you must carefully position, provide adequate skin and mouth care, perform active range of motion exercises regularly, provide superior bowel and bladder care, and adequate nutrition. You have the responsibility of preventing any complications that could cause long-term problems and have a negative impact on the rehab for these patients. And finally, don't forget any referrals for the individual patient depending on that particular patient's needs. This is the end of part 3 on brain tumors.